In this session, I will be discussing the importance of hyperplasia of endometrium, its risk factors, how to diagnose and manage hyperplasia of endometrium. We all know in a normal menstrual cycle, there is the growth of ovarian follicle, which secretes estrogen, which will act on the endometrium to cause proliferation. When the follicles mature, ovulate, and after ovulation, the follicle converts into corpus luteum, which secretes progestogen. This progestogen will act on the endometrium, making it secretory, and the degeneration of the corpus luteum lead to withdrawal of the hormonal support and menstruation result. When there is no ovulation, there is no production of progesterone, and there is unopposed persistent stimulation of the endometrium by estrogen can lead to undue proliferation, leading to hyperplasia, and if persisting, there will be atypia and leading to carcinoma endometrium. And the exact incidence of hyperplasia is not known, roughly about 1 to 3%, especially in a menopausal, postmenopausal bleeding. The proliferation or hyperplasia can be with atypia or without atypia histopathologically. And with atypia is a pre-malignant condition which, if persists, the chance of malignancy is about 8%. Risk factors for hyperplasia and endometrial carcinoma are similar. In a young woman and perimenopausal woman, the most common cause is chronic anovulation and PCOS. In a menopausal woman, the most important cause is obesity and HRT. In obese women, where there is a peripheral conversion of androgen to estrogen, and as the BMI increases, the chance of developing hyperplasia and endometrial carcinoma increases. 41% of the endometrial carcinoma occur in obese women having a BMI of more than 30 kg per meter square, and there is a linear increase with every 5 kg increase in the BMI. The sustained decrease in the BMI will decrease the risk of developing hyperplasia and endometrial carcinoma. Hormone replacement therapy with estrogen alone in patients with having a uterus can lead to endometrial hyperplasia unless it is supplemented by progesterone. Another important, even though rare cause is estrogen secreting tumors of the ovary like granulosal cell tumor or theca cell tumor. In women having a family history of malignancy, Lynch syndrome is one of the risk factors, and women who are on prophylactic tamoxifen is another risk factor for developing hyperplasia. Tamoxifen is a selective estrogen receptor modulator which will act as an agonist on the tamoxifen will act as an antagonist on the breast tissue to prevent breast carcinoma, whereas it will act as an agonist on the endometrium, producing hyperplasia, and if can lead to development of endometrial carcinoma. Clinically, this woman may present with a heavy menstrual bleeding, which will be usually preceded by a short period of amenorrhea. Menopausal women usually present with the postmenopausal bleeding. Coming to evaluation of the patient, of course, we have to take a meticulous history and clinical examination. In history, the pattern of menstrual abnormality, whether there is any amenorrhea preceding the heavy menstrual bleeding or the woman is having postmenopausal bleeding. Any history of drug intake should be asked for, and any history of previous history of breast carcinoma or family history of malignancy should be asked for. An examination, look for the BMI of the patient, look for any lymph node, especially supraclavicular and inguinal nodes. Per abdominal examination, look for any mass abdomen, which if there is a mass may suggest a ovarian neoplasm or a pyometra. Is there any ascites or not? Whether there is any hepatosplenomegaly. Should be followed by a examination of the genitalia, per speculum, and the bimanual examination. Bimanual examination, one has to look for the size of the uterus, any adnasal mass or deposit in the pouch or ductus. The first and foremost investigation is transvaginal sonogram. It is non-invasive, simple, and cost-effective tool for evaluation. Transvaginal sonogram should look at the endometrium, its thickness, the character, in presence of any fluid. Look at the myometrium and look at the adnexa for any abnormality. In a menopausal woman, the endometrium is described as a pencil, like a pencil line, which means it is very thin and homogeneous. If the endometrium is more than 4 mm, or if it is less than 4 mm but it is heterogeneous, or if there is a fluid in the endometrial cavity, all these merit endometrial sampling. In a reproductive age group woman, if the endometrial thickness is more than 8 mm, that merits endometrial biopsy. Endometrial biopsy can be done as an outpatient procedure using a Pipelli or a endometrial Vabra aspirator. If the sampling is insufficient, or if there is the histopathology comes with the atypia, or if the woman is on tamoxifen, then it merits dilatation and curettage. Histopathologically, hyperplasia can be of two types, with atypia and without atypia. With the hyperplasia alone, there may be plenty of glands may be arranged in a crowded fashion or back to back. Stroma may be abundant or scanty depending upon the severity of hyperplasia. If the cells, the nuclei show irregularity or increase in the size or nuclear atypia, then we call it hyperplasia with atypia. And the management depends on whether there is atypia or without atypia. In women without atypia can be treated with the progesterone. LNG intrauterine system is the first choice, which has more advantage, more regression, and the bleeding pattern, more acceptable bleeding pattern, and hence recommended by the RCOG as a first line measure for treating hyperplasia. We can also use progesterone, especially medroxyprogesterone 10 mg daily, which can be given cyclically or can be given in the second half of the cycle and should be given for minimum 6 months. In young women, we can also use combined oral contraceptive, which will cause atrophy of the endometrium. In tamoxifen users, LNG or progesterone or LNG IUS is not preferred because of the suspicion of increasing the recurrence of carcinoma breast. Hence, for them, it is suggested to do a hysterectomy, or those patients with high risk for surgery, we can go for a LNG IUS with regular sampling of the endometrium. Women with hyperplasia with atypia. The first choice is hysterectomy with bilateral salpingo-oophorectomy. In women, this is because there is a chance of developing to endometrial carcinoma about 8%, and there may be 40% chance of coexisting carcinoma endometrium. Hence, in women, especially in perimenopausal and postmenopausal women, hysterectomy with a bilateral salpingo-oophorectomy is preferred. In young women who doesn't want, who have completed the family, ovary can be preserved, but hysterectomy should be done. In women who wants to retain the uterus for fertility, or woman who is high risk for high risk for surgery and anesthesia, for them LNG IUS may be suggested with biopsy at regular interval at least once in 3 months. To conclude, hyperplasia of endometrium occurs whenever there is an excessive estrogen stimulation in the absence of progesterone. Hyperplasia with atypia is a premalignant condition which can develop into carcinoma endometrium in 8% of the cases, and there is a chance of coexisting endometrial carcinoma in more than 40% of the cases. Patients without atypia can be treated with the progesterone, LNG IUS being the first choice, and if giving oral progesterone should be given for minimum 6 months. In women with atypia, hysterectomy with bilateral salpingo-oophorectomy is the first choice. In women who want to retain the uterus or where there is a high risk for anesthesia and surgery, in such women should be given the option of LNG IUS with the regular sampling of the endometrium at 3 months interval. Thank you for the patient listening.